Hello again, Dr. White, back with the second video, same day, still not feeling well. So again, forgive me for all this stuffiness and that I have going on, but I do want to give you an overview this week. I was hoping that I was going to feel better and already have this recorded, but I'm not feeling better, so if I don't record it now, it's just not going to happen, or it's going to be too late. So I do want to review chapter on supervision and also the chapter on theories. And the theories chapter really is much more in depth than just theories, but we'll go over some of this information. So with supervision, you can look at this two ways. One is the supervisor, or two as the supervisee. So there's rights and responsibilities. There's, if you get to a supervisory level in the counseling field, there are certain rules, responsibilities that you're going to have to follow. Same is true to some degree for supervisees. So supervisees in counseling are required to follow the ACA Code of Ethics, which it states clearly in the code. So the supervision part of the ACA code is section F. And a lot of this is kind of focused more on what supervisees should do. But if you thought like a supervisee maybe was out of line, or there was some boundary issues or some of that, you would go in to look at the code to see maybe if there was a violation there. So starting with informed consent, which is F1, then you go into, it's just like any client informed consent. If I'm going to get supervision, I want to know what the supervision entails, how long it's going to be, where we're going to meet, all of the information, just like you would do with a client, you're going to do similar with a supervisee. Now, oftentimes, what will happen in counseling is you will go to get a master's degree in counseling, which takes anywhere 2 to 3 years. Then you will work post-master's for 2 years to become licensed. And then you will work 5 years as a licensed professional before you can get a supervision credential in most states. Some states require an additional 12 hours of education. There's different requirements. But that's basically kind of how people trend from being a counselor to a counseling supervisor. A lot of reasons people do it is, one, they've been in the field for a long time, but two, you can make money supervising people, because there are some agencies that are short on supervisors. So it is one way to increase income. So that would also go in the informed consent. How much, how often, all of those sorts of things. Oftentimes you will have a contract with supervision. And I did the 12-hour training for the state of Tennessee in all 3 regions. So if you were super interested in this topic, you can shoot me an email and I can send you additional information on that. So also there's the responsibilities of the supervisee, supervisor, and kind of what that entails as far as boundaries, relationships, mentorship, all of those components. Then you have methods of supervision is one of the things that was discussed in the book. Now this, it can be looked at several different ways. So there's different methods. So you're thinking maybe face-to-face supervision, or online supervision, or group soup, or individual supervision. But then you also have different supervision theories. Let's see if I can find a book. So there's a book by Clinical Supervision by Bernard and Goodyear, which is, this one's super old. I had it in my graduate program, but this is like the supervision Bible, has all of my tabs still in it. I still use it, but it just like counseling theory, just like you have Rogerian or Gestalt or solution focused or CBT, there are supervision theories as well. So there's the developmental model, psychological, there is a cognitive model. So there's different theories of supervision, and that dictates kind of the lens that the supervisor is looking at the supervision relationship through. So when I'm talking about types or methods or models, sometimes they can mean like one-on-one supervision versus group supervision, or they could be talking about like what theory a person is using to kind of like view that supervisory relationship. So if you're interested in that, you can type in basic supervision theories, and usually the Bernard and Goodyear stuff will come up and give you like the top 3 or 4. One of them is called the discrimination model. One is a developmental model. So it's pretty interesting information, and it kind of makes sense, like, oh, supervisees develop. So maybe they start out more timid with more anxiety, and then they grow competence and confidence, and then they continue to grow with their skills and their knowledge and their awareness. So they're developing as a supervisee. Same sort of thing that we think about with developmental models of counseling, to where our clients are also going through the different stages. Also talked about different supervision techniques. So some techniques is you show up to supervision and you just kind of report about how it went. So that is, they're just kind of taking your word for it on how you worked with that particular client. Other one is live observation, where your supervisor is sitting right in the room while you're talking to your client. Another one they use is like having the one-way mirror, where the supervisor is behind the mirror. I went to the University of Akron, and we had a supervision room to where a whole class could sit behind and watch a real session and provide feedback. There's also something called bug in the ear. So they used to have kind of like an earbud, and you would be able to hear the professor or the supervisor behind the mirror telling you stuff, and it would come into your ear. So they'd say, you know, get the client to focus more on feelings, or I don't know, whatever they think needs to be the focus. And then the client doesn't hear that, so it doesn't disturb the client, but you hear it. So that information, you'd be able to incorporate it in. Where I went to school at Akron, they had a screen, so the professors could type in, and then that was in front of the counselor. So if I'm looking at the screen and it's behind the client, then I'm seeing kind of notes or information that they want to me to have for that particular session. So there are a lot of different techniques that you can use with supervision as well. Sometimes we use audio recordings. I know in my master's program, we had to turn in audio recordings. Sometimes we use video recordings. Now in the master's program, we do require students still to record sessions with clients and then present that presentation to an entire class, and then we provide them group supervision feedback. Goodness, I'm sorry. Competence is also discussed in the supervision section. It's also in F2 and F5B. So what makes you competent as a supervisor, I talked about in the last video. It's also going to make you competent. I mean, what makes you competent as a counselor is going to make you competent as a supervisor. I'm sorry, my head is so fuzzy. So education, experience, supervision of supervision is even a thing. So in my doctorate program, I took supervision courses. So I supervised a master's student, and I was the supervisor. But I had a supervisor. So a professor was supervising me as a supervisor. And some states are even requiring that before you get the credential. So there's some with competence there. Online supervision, there can be some downfalls with that as far as confidentiality. What if you get cut off? How, if I'm going to talk to you, let's pretend you're the supervisor, I'm going to tell you the information. Well, my kid is in the other room. She just knocked on the door a few seconds ago. I don't know if you heard her. I was like giving her the mama snap to get out. So would they hear that information? So there's other things that can happen with online supervision. Now, some of this has been, you know, making sure you're using a HIPAA compliant software, those sorts of things. In the state of Tennessee, you used to have to get special permission to do online supervision, and that was basically for rural, I hate that word, community counselors who there wasn't a supervisor close. So they'd have to drive like to Nashville to get supervision. So the board would grant them so that they could do online supervision. Now that we've had COVID, a little bit different. I think we're definitely exploring how to do all things with technology better. So, okay, supervision and multicultural counseling. or how the multicultural component comes in. As with everything, multicultural component is extremely important. Same in supervision. So I'm actually doing a presentation in Baltimore in November on this exact topic. I'm presenting with two other professionals, Dr. Ruffin and Dr. Dangerfield, and we are presenting on BIPOC women in supervision. So Black, Indigenous, people of color. Both of my co-presenters are African American, and I did supervise both of them. So we're going to, at one point, like before they finish their degree. So we're going to talk about some of those dynamics of race, gender, those sorts of things, and how they play out in a supervisory relationship. So maybe a supervisee has some things going on, some additional stressors that aren't really my stressors, or I don't even see as an issue based on maybe my gender, based on my socioeconomic status, based on race, all of the cultural dynamics that make me up. Also, many people of color oftentimes feel underrepresented. So you'll see a lot of white supervisors with supervisees that might be hold a minority status of some kind. And so then there's even this larger power differential. So just being aware that there is a dynamic there. It's not discussed a lot in the supervision books, which is why we're doing a presentation on it in Baltimore. So it's something that definitely needs to be taken into consideration. And it's not just race. It can be gender. It can be, several other things as well. Multiple relationships. So that's the last component to discuss in this chapter. And with the multiple relationships, so oftentimes maybe you're working at an agency and you're working there for 3 or 4 years. So you're colleagues and you go out to lunch with people and maybe they know you personally and you hang out. Well, now all of a sudden you've been there for 5 years and you have a promotion and now you're their supervisor. Okay, so now you have multiple relationships because just 2 months ago or a year ago, they were your friends. So maybe you know things about them that a supervisor wouldn't typically know. Or now there's a new power differential. So how do you navigate those multiple relationships? Very similar to with clients. You would want to document it. You would want to keep supervision notes. You'd want to talk about it, etc. And the example that I used of Dr. Ruffin, her and I had that exact thing. Like, I didn't supervise her, and I knew her like as a person. And she even came to the hospital to pick me up once when I was hospitalized anyways. And then she was in the doc program, and I was teaching a doc class, and I was like, okay, like, this is kind of weird. Like, she's one of my students, so I want to make sure not to give her preferential treatment because she's also like one of my friends, like somebody that would pick me up from the hospital. So I went to my supervisor and said, like, I don't know how I feel about this, and I needed to kind of process through this boundary blur and these multiple relationships, and talked about it with my supervisor, ended up talking about it with Dr. Ruffin, documented it because, I did end up supervising her later on. So that was a different dynamic because I don't supervise all of my students, and I'm not friends with students because there is a power differential and boundaries and all of those sorts of things. But stuff like that can come up and does come up. So that's why it's addressed in the code. Okay. I feel like I talked really fast. I feel like I need a drink and I don't have one with me. So I'm just going to power through it. One more chapter to go. Theories. Theories was the kind of overarching title, but there was a lot of discussion on diagnosis, assessment, etc. So it starts off talking about counseling style. And theory plays a part in that. So style can be a lot of things. So maybe I identify as cognitive behavioral or solution focused, or use narrative therapy or EMDR or Gestalt or person-centered. I mean, there's all these different counseling theories. So how I approach an issue as somebody who identifies as cognitive behavioral counselor is going to be different than how somebody who identifies as person-centered or Gestalt or EMDR or, whatever. So not only are they going to come at the client's presenting concern with a different lens on, but they also have their own personal style. So I tend to be a little more direct. Some people in the South say it's because I'm from the North. I don't know. It's just, I think like it's part, I don't know if it's cultural. I don't know if it was learned. I'm not sure. Anyways, so like that can be part of my personal style as well. I tend to use humor a lot. So there are different stylistic things to where I might lean in more or be closer to a client or make more eye contact, whereas somebody else might not. But I also might use a particular theory or some techniques, or another client or counselor would use something else. So then you have that. So that can be very different for the different, I'm sorry, I lost my train of thought. So that can be very different depending on the counselor. Having a fuzzy brain again. Then we have the goals of counseling. So what are the goals of counseling? Do we make that up or do the clients make that up? And if I go in with an agenda, does that take away the client's autonomy? Is that me doing, taking away those principles that we talked about or that we've talked about in the first several weeks? Yes, because essentially the client is the one to control the counseling session and to have those goals. Okay, so we would all probably do a basic agreement on that. But where it comes into play is, what if I have a client who's coming in and they don't want to be diagnosed? So do we not diagnose them? Because then, is that not neglect or maltreatment? You can also have goals of counseling. So let me think of another example. So say, for instance, I have this a lot in addictions counseling. So I have a client, they'll come in, maybe they want to deal with their depression, but their goal is not to stop using. Like, I don't want to stop using alcohol, but me as the counselor thinks that that is contributing to the depression because alcohol is a depressant. So how are you going to feel better when you're coping with your depression by taking a depressant? And I see that the alcoholism is an issue, but the client doesn't want to deal with that. Okay, so say on the treatment plan, whatever, I decide, okay, we're just going to deal with the depression. We're not going to deal with the alcoholism. We won't put that as a goal, etc. That client gets in a car wreck, kills 5 people. Then I get taken to court because I'm the client's counselor. Well, counselor, you knew that they had an addiction issue and you chose not to treat that issue. They clearly told you that they were using this much alcohol, this frequently, whatever, and you chose not to treat that. So there is some ethical responsibility on us as the counselor, as far as how to treat those sorts of things when a client doesn't want to address the issue. You could still, this kind of gets into a higher level conversation, but maybe, okay, we don't have to deal with that now, but at some point we're going to want to talk about that, even if it doesn't meet a treatment goal. And I'm still going to document that I wanted to talk about this, that I see it as an issue, that the client is not ready or is not in the stage of change to address that issue, because I'm going to protect myself through documentation, because if you didn't document it, it didn't happen. So goals of counseling, and that can look very different than goals in case management. Goals in counseling typically are things that are it's about reducing the symptoms, but the objectives of how they're going to meet that goal are things that are actually done in the counseling session. If you decide to get a master's degree, you'll learn more about that in the documentation course. Techniques of counseling. I think this one is an important one. And this comes to C7 in the ACA Code of Ethics with the techniques. And why I think this is important is because this particular code in 2014 was updated, obviously, in 14, but more information was added about this topic specifically. So C7A says Sorry, trying not to get too close. When providing services, counselors use techniques, procedures, modalities, and grounded theory that have been empirically or scientifically or have a scientific foundation. So here was the issue, because that used to not be in the code. So there's something called conversion therapy. If you're not familiar, it is a technique, and I use that loosely, that converts people who identify as LGBT into being cis hetero as far as gender orientation or sexual orientation. So it is converting them, getting rid of the gay. I mean, it's been all kind of things. So this is still is practiced. You can Google it. There's probably somebody in your area who offers conversion therapy. It was extremely popular for a while. There were conversion camps that parents used to send their kids to, all kind of stuff, which a lot of trauma has came out of those. And there's no research to support the efficacy of this particular technique. So what counselors were doing is, well, I'm going to use this technique. Okay, but it's not empirically founded. So I can't ask a client to stand on their head. They might feel better if they stand on their head, but if there's no support behind that, then I can't be asking them to do that, because there could be risks involved as well. And so then people who are practicing conversion therapy were saying, okay, but what if a client comes in and requests conversion therapy and they want to be converted? And they said, okay, this is where the code has changed. My voice is leaving. So this is where the code has changed, in that it has to be empirically founded. It doesn't matter if the client's coming in requesting it. Just like I can't go in and request an appendectomy if my appendix is fine. Like, no, there's no medical reason for me to take out an organ. So I'm not going to do that. Same thing is true. It has to be empirically founded. There have to be some kind of evidence for it. So that's where this particular kind of code came about and is newer in this generation. I'm sorry, I don't know how much longer I'm going to last. Then there's the assessment and diagnosis, which is section E. There is diagnosis. Your book talks about the pros and cons. So if you're looking at some of the cons, you want to explore E5D, and just talks about those negative associations with it. You also want to think about insurance. So it used to be certain diagnoses, personality disorders were not covered by insurance, and now it can be hit or miss whether anything is covered by insurance. But also they want a specific code, and it's so complicated. I'm teaching a DSM course this term as well, and the DSM just in March came out with a new book. I actually have it today. So this is just the brand new in March diagnostic and statistical manual of all the different diagnoses. So you can imagine when I have a book that's 1,000 pages, how complex that can be. There is a lot of research on racial bias in diagnosing. So oftentimes people of color, BIPOC populations, are diagnosed to be more severe and are diagnosed with things like psychosis and hallucinations more frequently, but not because they have them, but because their behavior is seen as more threatening, etc. There's tons of research on it. It's actually really sad. So we want to be mindful when we're assessing people to see what their diagnosis should be, of what assessment we are using. If that assessment has been normed only on heterogeneous white populations, are we using it for other populations, and is that ethical? So there's that as well. Ethical dilemmas. I could tell you many ethical dilemmas with diagnosis. Tests in counseling. So that goes back to assessment. test, and we use those to diagnose. So all of those are kind of interrelated. So essentially, like the client comes in, they tell us their symptoms, we're assessing their symptoms. Sometimes we'll give them an additional test. Maybe we'll give them the SASI if they have addiction issues. Maybe we'll give them the Beck Depression Inventory if they have depression, or the Beck Anxiety Inventory if they have anxiety. So there's different assessments that we can give people to kind of support our diagnosis. Then we take that test data and our assessment of their symptoms, and we say, okay, let's make goals. And hopefully we're working with the client when we're making those goals and objectives. And then we say, okay, what does research say of how to address this particular diagnosis with these particular goals? Okay, CBT is known to treat addiction disorders and to get some behavioral change and to, reduce addiction symptoms. Okay, so let's use CBT. So you see how it's all kind of intertwined together, which is why it's all in this same chapter. So just to give you an example before, I thought this was going to be like a 10-minute video. I'm so sorry. Just to give you an example before I end this one. So like I already talked about, there's ethical issues in bias and how we diagnose people, and that can be for several reasons. One is I could have a bias and I could receive the other person as being more combative, or just because they speak louder or they speak with their hands. Or it can be because certain populations have less access to insurance. So when they first get the symptoms, they aren't going to the doctor because they don't have insurance. So they wait until their symptoms get really, really off the chart before they go. So then they are more severe when they come in because they waited so long. So a couple different things at play there. Other things as far as testing goes. I know one of my professors shared an example with me about a student who was in counseling. They were testing this particular student, and they were a child, and it was like, which one of these things don't belong? And there was like a pizza, a hamburger, and a cactus. And she chose the pizza, didn't belong. And they were like, okay, like that doesn't make sense. A pizza and a hamburger go together. But to this child who was of Hispanic origin, they eat a lot of the cacti flowers with breakfast, but she doesn't eat pizza. So in her family culture, etc., she was like, we don't eat that, but I do eat the flowers off the cactus, and I do eat hamburgers. So to her, those two things went together. But to typical Western white philosophy, we might think, I'm from Ohio, so like Midwest, I'm thinking the pizza and the hamburger go together. So something that simple could be culturally biased. And if there were a bunch of those like that, would we think that she doesn't have insight, can't have reasoning? There's tons of different examples of how testing can be biased. So there's information, obviously, in your code of ethics that says we need to make sure that we are using the right tests, that they're in the right language, in the person's mother tongue, and maybe even if it's somebody with a disability, so maybe they can't see it correctly. There's all kind of things that go on. And if we're just giving everybody who shows up the same Beck Depression Inventory, is that really fair? And is that giving us accurate results, etc.? So that's some of what the theories chapter talked about. Sorry that I sound so horrible. Sorry that that video took so long. But I hope it gives you an overview of this chapter. I hope all of you are well, stay healthy, and we'll see you next week. Thanks, bye.